Welcome everyone to this STOP-TB partnership webinar on the next generation SIILTIBCY skin test, also known as SIILTIBCY. My name is Wayne Van Gemmerts, and I'm a diagnostics technical officer here at STOP-TB, and I'm joined today by my colleague Beatrice.
Hello, everyone. My name is Beatrice Kirubi. I'm technical officer on the TB-Rich team here at STOP-TB. We're very happy to have you with us today for this webinar on the SIILTIBCY skin test. We've organized this webinar to familiarize you with the tests and how it works and share with you information about the procurement and implementation. And we are very excited to have today 3 speakers from Bangladesh, Uganda, and India who will be sharing their experiences so far using the tests.
And before we start, just a couple of quick housekeeping notes. Firstly, the webinar is being recorded, and a link to the recording, as well as all of the presentations, will be shared with all people who have registered. If you have a question, please enter it into the Q&A box, not the chat box. And without further ado, I would like to first welcome our Deputy Executive Director of the STOP-TB Partnership, Dr. Suvanan Sahu, who will be making some opening remarks. So over to you, Sahu.
Thank you, Wayne. Good morning, good afternoon. It's great to see so many people join for this webinar. I see 167 people there. We had a huge number of registrations. Great to see the interest. And as we proceed, maybe this number will increase further. So first of all, from STOP-TB Partnership, we would like to welcome all of you to this webinar. As you know, 1 in 4 people globally are infected with Mycobacterium tuberculosis. Not all of them will get into disease, but some of them will. And this number, huge number of people, close to 2 billion, who are infected with TB, we have to do something about them. There are currently recommendations on what can be done. For example, there are recommendations for screening of contacts of TB people, people with TB, and putting them on TB preventive treatment. But we are aware that this has not taken off to scale. We had in 2018 a UN high-level meeting which set some targets for TB preventive treatment, but the world failed miserably. This was the target that was least achieved. We again had a UN high-level meeting in 2023. There are even more bolder targets to achieve on TB preventive treatment. But we have to see how we go forward. So far, the progress has been less than what everybody expects. And one of the issue there has been that you can obviously put on TB preventive treatment without doing a TB infection test. But that works well for contacts who are young children below 5 years, people who are living with HIV. But when you come to that group, which is above 5 years, and you think about initiating them on TB preventive treatment, we have seen in many places there is a barrier. And the barrier is, should we test, should we not? Both has pros and cons. And if we test, what is the test that we will use? So in the past, we had the good old tuberculin, but it's not accurate, as we know. Now we have new tests. And we also have the blood-based EGRAs, which have been there for some time, but we know that they are expensive. They require a lab infrastructure that in many high-burden settings you may not have. So today we will be discussing this test, which belongs to the new generation of skin tests, which gets over the disadvantage that tuberculin had, is more accurate, more specific, and it is available. And you may have seen that we had announced this from STOP-TB, that the price is very good. We haven't seen much of demand from countries and partners to procure them and procure this test and use it. So here today we have, you will hear from some early implementers and some plans to scale up. We are very happy also that India is here, and we will also hear from them, and a number of TB Reach projects across the world. So thank you all for joining this webinar. This is an important one. I must say that unless we prevent TB, we can diagnose and keep on treating, but we will not end TB. We will reduce the number of deaths, but as you know, the incidence is not declining. We have to do many more things. We have to diagnose TB early, but also one of the things we have to do is to prevent people who are at risk of developing TB disease, and these are people who are already infected. So with that, I hand it over back to Wayne and Beatrice.
Thank you, Sahu, for those words. So next, I'm going to give an overview of the test and describe some of the procurement and implementation considerations. So I will be sharing my screen now. Just give me one moment. Okay, I think you should all see it in presentation mode now. So firstly, just some basics. What is the SIILTIBCY test? This is a novel diagnostic skin test for detecting Mycobacterium tuberculosis infection, also called latent TB infection. These skin tests should not be used for diagnosing active TB disease. This SIILTIBCY test uses antigens that are specific to Mycobacterium tuberculosis. So these are the same proteins used in the blood-based laboratory IGRA tests that Dr. Sahu made reference to, the ESAT6 and the CFP10 proteins. And the way it works is these antigens elicit a localized reaction in people who are infected with TB, and then 48 to 72 hours after administration, a possible induration is detected visually. The SIILTIBCY test is manufactured by the Serum Institute of India in Pune, and it is marketed in India as SIILTB. So that's why you'll hear it being referred to as either SIILTIBCY or SIITB. Now, about its approval status. So back in 2022, the WHO Global TB Program made class-based recommendations on the use of MTB antigen skin tests. And there are 3 skin tests that are in this recommended class. So there's the DIA-SKIN test from Generium in Russia. There is the CTST from Zhaifei Biologics in China. And then there's this SIITB SIILTIBCY test. Now, with regard to the quality criteria of the Global Fund to allow for its resources to be used for procurement and to be eligible for inclusion in the Stop TB Partnership's Global Drug Facility GDF catalog, for IVDs, WHO recommendations are sufficient. However, these skin tests are not IVDs. These are in vivo tests that are injected into patients, so there are stricter criteria. So the SIILTIBCY test has become the first test eligible for procurement using Global Fund resources and through our GDF, because firstly, it was approved by the Global Fund's expert review panel back in August 2024. And then at the beginning of this year, it received market authorization in the EU. And the European Medicines Agency is a stringent regulatory authority. And just to note that also there is the WHO pre-qualification pathway now open for skin tests, and the SIILTIBCY test is currently undergoing evaluation. So that's why the SIILTIBCY test is in the GDF catalog, and the DIA-SKIN test and CTST are not yet in the GDF catalog. Dr. Sahu already made reference to the advantages of the SIILTIBCY test. First, it has enhanced specificity compared to tuberculin. So there are fewer false positives because it uses these MTB-specific antigens. So it minimizes the cross-reactivity with BCG vaccination and with non-tuberculous mycobacteria. Secondly, this ease of transition. Many countries already have some experience using tuberculin, the tuberculin skin test. So there's a very similar administration and reading procedures to the tuberculin traditional MANTU test. And there's no laboratory requirement for skin tests. So unlike the IGRAs that are currently WHO approved, SIILTIBCY doesn't require any sort of laboratory infrastructure, so it makes it suitable for use in resource-limited settings. About technical specifications and implementation, starting with dosing, dosage and packaging. So the dose is 0.1 milliliters, and each vial contains 1 milliliter of solution, so it's sufficient for 10 doses. Similar to tuberculin, it does require a cold chain, so it has to be stored between 2 and 8 degrees centigrade, and it cannot be frozen. The shelf life is 24 months at manufacture. And just to note, if a vial is opened, then it can be used for up to 28 days, provided it is stored between 2 to 8 degrees Celsius. For administration, it's an intradermal injection into the inner forearm. So you need to have trained healthcare workers and appropriate syringes. And the syringes that should be used for this would be the 0.1 milliliter disposable syringe or 1 milliliter single-use disposable syringe. And the gauge of the needles, these are the fine, depending on country regulations, it's generally a 26 or 27 gauge needle that's used for an intradermal injection. Results interpretation, a possible induration should be read between 48 and 72 hours after administration. So this does require the patient to come back. And an induration of over 5 millimeters indicates MTB infection across all populations. There are contraindications and instructions for use for special populations, including pregnant and breastfeeding women. So this is all described in the instructions for use. It's a very affordable test, as Sahu said, so the GDF was able to include it into its catalog at a price of $1.50 per test. That is $15 for a vial of 10 doses, and all countries are eligible for procurement through GDF. Now, to order it, your orders must be in multiples of 120 vials. This comes to 1,200 doses. And this is due to the shipping requirements. So there is a special box that is used that includes cool packs, and therefore the size of the box requires multiples of 120 vials. The syringes for intradermal injection are not available through GDF and must be procured separately. If you don't have a mechanism to procure them, you can go through the UNICEF supply catalog. They offer syringes as well as safety boxes for disposal. And about shipping, since it does need to be stored between 2 and 8 degrees Celsius, it's shipped by the Serum Institute of India in temperature-controlled boxes with cool packs. So this maintains the 2 to 8 degrees Celsius for up to 90 hours. But it's therefore very important to have prompt customs clearance, especially in airports that don't have cold storage rooms, to preserve the integrity of that cold chain. So if you have any questions about that, you can reach out to the GDF country supply officer for your country and discuss possibilities and routings of airlines. So we're excited to have 3 speakers today. We have Dr. Sanjuti Kabir from ICDDR Bangladesh, and Dr. Alex Kitia Mwesi from Walamu, Uganda. These are 2 projects that have been using the SIILTIBCY test with support from Stop TB Partnerships TB Reach. And we're also very excited to have Dr. Veena Dewan from the Central TB Division of the Government of India. So you can always reach out to me, Wayne Van Gemert at Stop TB Partnership. Thanks for your attention. And I am now going to pass on to Dr. Sanjuti from ICDDRB. So please go ahead and share your screen now. Thanks.
So, thank you so much, Wayne, for your introduction. And I'm going to share our slides. Is it visible?
Yes, please go ahead.
So thank you very much. Good evening to all from Bangladesh, and thank you so much for inviting me to share our Bangladesh experience on evaluation of this test. So basically, all these things have been covered by Dr. Sahu and Wayne. So I'm skipping this. Directly, I'm going to our study objective. So our objective was to assess diagnostic performance of CYTB for detection of TB infection among household contacts of bacteriologically confirmed pulmonary TB patients. It was a cross-sectional study which was conducted in North Sindhi district. This was a implementation district of our Wave 10 project. And our population was household contacts. Our sample size was 800. And our data collection period was August 24 to January 2025. On the right-hand side, you can see the study flowchart. Our project staff visited the household contacts and enrolled them after receiving informed consent. And each of the individuals underwent CYTB test, and the measurement was taken between 48 and 72 hours. In addition, 4 ml blood was collected from each of the participants, processed at field site lab, and then transported to ICTDRB microbacteriology laboratory to perform quantiferon. The individuals who were positive either on the CYTB or quantiferon underwent chest X-ray, and the X-ray positive suggestive individuals were referred to the nearest facility for further TB evaluation, and the non-TB suggestive individuals were considered as TB infection. So the individuals were excluded from the study who were on anti-TB treatment or TPT during enrollment period, who were administered with TST within 3 months, with severe disease condition, and who may have poor compliance or any circumstance affecting the follow-up. We received an online training provided by the Serum Institute of India and MyLab before field implementation, and then we started our activities. Here are some pictures of the online training and field implementation. These are some snaps of the administration procedure, and the individuals, as already Wayne mentioned, that the individuals who had induration of 5 millimeter or more were considered as positive. So here goes some preliminary findings of our study. We found CYTB 15.5% positive, whereas the positivity of quantiferon was 28%. And compared to the quantiferon as reference standard, the sensitivity of CYTB was 42%, specificity was 95%, and accuracy was around 80%. This slide shows the test positivity in different age groups and gender. You can see here the positivity of CYTB is a bit lower than the positivity of quantiferon across all age groups and the genders. And this slide shows the test positivity in different conditions. For example, diabetes mellitus, hypertension, COPD. And you can see here that the positivity of CYTB is higher among the individuals with diabetes mellitus, hypertension, and COPD. And the positivity is similar to that of quantiferon. In this flowchart, we have shown the both positive individuals, how many of them have identified as TB and TBI. So here you can see that 91 individuals were positive on both tests, and among them, one was diagnosed as TB through investigations, and 90 of them were found TPT eligible, and among them, 62% were enrolled on TPT. We want to show you the right-hand side of the flowchart, and you can see that the additional positivity of the CYTB test over quantiferon, 30 individuals were positive on CYTB, but they were negative on quantiferon test. And among these 30 individuals, 2 were found as TB positive. However, and the remaining 28 were found TPT eligible. And among them, 53% were enrolled into TPT. To see the patient safety, we closely observe participants for any side effects after CYTB administration. We counsel them and advise to report any problem. We followed them up between 42 and 72 hours for taking measurement and also after study completion. None reported any complaints, only when we followed them up between 48 to 72 hours for taking measurement, only around 20% had mild discomfort. We faced few common challenges during enrollment. For example, some participants had concern about the test. They had, some of them had misconception about the COVID-19 vaccination. For example, some experienced some allergy after taking the vaccination. So they had some restriction on taking out the test on the skin. And also, participants' unavailability during measurement was a big challenge. Our project staff visited the households and administered the test in the community, also visited their household for taking the measurement. But what happened when our field staff visited the household, sometimes they had to wait along, and also they had to make repeated call to the participant to make them available for taking measurement. Another thing was maintaining cold chain at field site, because we went to the field site and we transported the reagent, maintaining the cold chain. So we had to manage the freezer and the refrigerator to store the cold reagent and the ice pack at the primary healthcare facilities. Participants' refusal to perform chest X-ray, gene expert, and also physician's consultation was also a big challenge. And another problem was TPT adoption for the eligible TPT individuals. So we mitigated these challenges with repeated field visit, counseling, involving the local authorities, and also providing the test cost support. So for programmatic implementation, we should consider some points. For example, the local field staff who are relevant for test administration, they should be trained properly for the testing procedure and the measurement. And also logistics should be ensured properly. And as I have already mentioned, that cold chain maintenance is essential. So these all the logistics required for the cold chain maintenance should be available there. And physicians should be oriented on the test acceptability. Before implementation, we oriented the physicians and we had a series of field visits so that physician can accept this new test. So this point should also be considered, and participants' motivation on test measurement and further follow-up should also be ensured. So in conclusion, we can say that CYTB is safe, easy to administer. It can detect TB infection. However, it had less sensitive than quantiferon. However, CYTB additionally detected TB-infected individuals independently. Its higher specificity indicates that it is beneficial for using to exclude TB infection. As I have already mentioned, that TPT enrollment was challenging. However, compliance was good among the enrolled participants. We recommend larger scale clinical trial in different population to validate the findings and determine the cost effectiveness compared to TST, which is widely available in Bangladesh. So we acknowledge a National TB Control Program, local health authorities, Stop TB Partnership, and BRAC for their support. And also we thank our co-donors for our relentless support. Thank you so much.
Thank you very much, Sanjuti, for that very informative presentation. If any participants have questions that are related to Sanjuti's presentation or to Wayne's presentation, you can write them now in the Q&A box. If they're relatively straightforward to answer, then we will try and answer now by writing. Otherwise, at the end of the presentation, during the Q&A session, we will hopefully still have some time to discuss some of the questions. So now I would like to invite our next speaker, who is Dr. Alex Kitiamwesi, a research scientist at Walimu, Uganda. Alex, the floor is yours.
Thank you, B. I hope I'm audible enough. Good
Yes.
morning, good afternoon, and good evening, depending on where you are. My name is Alex Chitiamwes. I'm here to talk about the feasibility and acceptability of integrating SIILTIBCY into home-based contact investigation for TB infection in Uganda. So this was part of a larger before and after study, which we implemented between March 2023 and December 2024. Our target population, the initial focus was really on children under 5 years of age and individuals living with HIV. However, we expanded this to include HIV negative contacts above 5 years, much as some did not have confirmed TB infection. So the project interventions to walk you through this, the larger project had an educational booklet which was aimed at teaching index patients to identify their household and close contacts, and also teach these people about TB and TPT. What we did was to also task shift the contact investigation from the healthcare workers to community health workers who had time, and then also introduced community health rider services using motorcycles. These ones were very key in transporting community health workers, the contacts, sputum samples, and TPT between the facilities and homes. We also added an intervention of monthly meetings between the different individuals to share experience and improve practice. Because the tests for TB infection were not routinely used in our setting, we introduced SIILTIBCY and incorporated this into the larger project. This was done at 6 high-volume facilities out of the 26 that participated in the larger study. Of course, this came with a few modifications because SIILTIBCY required a cold chain management, maintaining a strict 2 to 8 degrees cold chain. We leveraged the existence of refrigerators at the facilities to store our SIILTIBCY. For a few refrigerators that did not have temperature monitors, the thermometers, the project procured these and also introduced temperature monitoring logs. So on a daily, we would have the temperature recorded after a given interval of time. We also procured vaccine carriers because our nurses would need these to go out in the communities to administer the test. The vaccine carriers in the photo here was fitted with temperature monitors, and every time one would get out the drug, they would first record the temperature reading. So in set, we have our rider with a vaccine carrier in a bag. So we also did hire and train nurses to place and read the SIILTIBCY. Remember, in the larger study, we were relying on community health workers. These are not allowed to administer injections, so we had to hire nurses who underwent training about the project, the larger project, and then we also gave them the theory behind the testing for latent TB infection and how to use the SIILTIBCY. We also did some procurements for the syringes, as earlier mentioned. We used the 1 ml gauge that was used, the 1 ml syringe, sorry. And then also procured safety boxes to ensure that the sharps are properly disposed of. The training was really emphasizing the practical aspects. We used chicken as, the dummies to train these nurses on how to place the test. As you are aware, the test is affected very much by the technique one uses to place it. You have to ensure that you're in the intradermal area before you push. And then after the training of the nurses, these would go out in the homes of the index patients. They would explain the study procedures to the eligible contacts, document reasons for declining the test, and administer the test to the consenting contacts. They also provided information on how they should treat the injection area and any anticipated side effects, plus the action, including calling the nurses. So here we have some images, the papules resulting from the injection with SIILTIBCY. And ordinarily, one would expect the participants to maybe visit the facilities to have their readings done after the 48 to 72. But because we were going to their homes, we sort of came up with a reminder system. We leveraged the REDCap to create reports. On a daily, the nurse would see which people were due for reading, and also used automated alerts from REDCap. Every time it was approaching 48 hours for the reading, the nurse would receive automated emails at an interval of 30 minutes, that is 2 hours to the real time of reading, reminding them to go and take the reading for a given contact. Here is a sample that I'm sharing. And the reading is also important that it is done well. We used the ball pen technique, the ballpoint technique. They would draw a line like 2 centimeters from the margins of the induration, and then they would move the pen towards the center. At the point where they felt resistance, they would mark that and then do the same on the opposite side of the induration, and use a flexible, non-stretchable ruler to measure the diameter of the induration. As earlier noted, a diameter greater than 5 millimeters was indicative of a positive test. The results from this endeavor, we screened a total of 1,255 contacts. These were the ones eligible for the testing, and 92% of these accepted to be tested. However, 24 individuals representing 2% were unavailable for the reading at 48. Sorry, I went off. We had a total than 100. Can you hear me?
Yes, we hear you now.
Yes.
Okay, sorry. So we had a total of 1,129, or 98% completing the test. And of these, 272 or 24% were positive, and 96% of these accepted to start TPT. The reasons given for declining the testing were fear of injections, lack of symptoms. Some people felt they were not sick and there was no need to take a test. We also had skepticism of the TB infection. Some people thought this was really research, and because they had issues around COVID vaccines, the reactions they had received prior to the vaccination, some feared that maybe the reactions would be severe, and then around 7 declined because they would be unavailable for the reading. We incorporated a small study to assess for adherence to the TPT. What we found with the isoniazid tests with isoscreen, the adherence rates were low in individuals who had initiated TPT without prior testing. These were found to be at 33% non-adherent compared to those who had a positive skin test. So the test was not only diagnostic, but it sort of reinforced behavior to adhere to the TPT. We also conducted qualitative interviews with index patients and their contacts, plus health workers. And these were some of the findings. The contacts valued the services because they were receiving these at home. They didn't have to travel and spend the time on their way to the facilities. Everything was done from the comfort of their homes. The testing also acted as a reassurance, fostering trust in the process, and people were made to adhere to their TPT because of the result having tested positive. Some had anxiety over the outcome of the test during the waiting period, and others feared. They declined for fear of stigma in case the test turned out to be positive. There was also injection anxiety and the pain-related concerns, especially among women and children. So some were resisting the TST. As mentioned earlier, there was also skepticism. Some viewed the test as experimental, but would eventually accept to start the TPT due to the perceived risk. The health workers appreciated these tests very much. Because of the low test positivity, there was a reduction in the drugs given to the patients, so that the drugs were only given to individuals who had a positive test results, and this reduced on the incidences of TPT stockouts. The challenges, some have been mentioned by my colleague from India, but what we think is that the healthcare workforce, people usually struggle with the placement and reading, but this improves with continuous supervision and mentorship. For every 50 readings, 10 would be done with the study medical officer. So we sort of monitored this throughout. The challenges for contacts receiving the test, there was inconvenient test reading timing, especially for school-going children and working adults. And these missed the reading for the 48 to 72-hour window. We also had some logistical constraints, which led to poor adherence. For the operational challenges, in addition to what my colleague from India has given, we think there is need for practical guidance, especially in the early implementation stages, because this enhances the health work proficiency. So there should be mentorship. In conclusion, integration was feasible and highly acceptable in Uganda. And without these tests, up to 76% of the contacts would have received the TPT. As we mentioned, the focus was the children above 5 years who were HIV negative. And this is a group which constituted around 80% of the contacts. The next steps, we collected some cost data, and we will be providing information on whether this is a more cost-effective approach than treating all contacts for latent TB without testing. Over. Thank you for listening.
Thank you, Alex, for that very interesting presentation and sharing your experiences. I see we have quite a few questions coming in the Q&A box, so hopefully we'll have some time to discuss them at the end. But I would like to introduce now our final speaker, Dr. Veena Dhawan. She is from the Government of India Central TB Division. So Dr. Veena, the floor is now yours.
Thank you, Wayne, for the invitation. And I congratulate my earlier two speakers for the excellent presentations that they have made. And I thank Stop TB Partnership for giving me this opportunity. Could you please unshare your slide so that I would be able to share mine? Is my slide visible?
Yes, we see it now.
Yeah, thank you. So I'll be taking you briefly towards how we are implementing the TB preventive initiative in our country. What is our experience with SIILTIBCY, the learnings from the program, and way forward for it. So India's policy for TB prevention is embedded in our national strategic plan, where parallelly, along with identifying all TB cases and treating them with quality drugs, we are also ensuring that we prevent the emergence of TB infection and breakdown to disease and recurrence. And we are building our systems accordingly so that we are able to give a comprehensive cascade of care to all the patients or all the vulnerable population. Under TB prevention, we have 3 strategies in place. One that we have been talking about is TB preventive treatment. Secondly, vaccination, we give it to our newborns, and also we are doing a programmatic study with it of vaccinating adults with BCG vaccination. Third is airborne infection control that we do in high-risk zones, that is the DRTB centers, and also AIC to be done in the community and lower facilities. When we talk about the National TB Preventive Treatment Policy, we are focusing towards 3 main populations for TB preventive treatment. One are those with people living with HIVs. Secondly, all household contacts of pulmonary TB patients and the other risk groups. That includes people who are on dialysis, immunosuppressive drugs, alcoholics, malnourished, diabetics, and those who are staying in congregate settings. There are various regimens that are available under the program, which we are providing to those who are testing positive. We had a special campaign done in the last 3 months for 100 days, where we were trying to identify those with vulnerable populations who are at high risk of having tuberculosis. And those who were detected not to be having tuberculosis were then considered for starting TPT after doing a TB infection testing on them. So these are the overall population where we are planning to scale up the TB preventive treatment. And during the 100 days, we did reach out to a number of vulnerable populations, especially those on dialysis, healthcare workers, minors, people living in prisons, people with silicosis, undernourished population, and those living in urban slums. We are now working towards expanding our TPT reach to the other populations as we go ahead, but these are a few which we already touched during our 100 days campaign. If we look into the algorithm that we follow, as I mentioned, that these are the 3 target population that we are trying to focus on for TPT. The HIV positives, as was already mentioned, we just rule out TB in them and then we initiate them on TPT. While those below 5 years of age, we just rule out tuberculosis in them, and in case they are negative and they are close contacts of a TB patient, they are initiated on TPT. While those who are above 5 years of age, we expose them to TPT, to TB infection testing. And in case they are positive, then X-ray is done to rule out TB in them. And then in case it is all negative, then they are considered for TB preventive treatment. So at present, we have 3 tests available under the program. One is TST, IGRA, and SIILTIBCY. As we had already mentioned that compared to TST, we have better sensitivity and specificity seen in IGRA and SIILTIBCY. It is when we talk about IGRA, as was already mentioned by my colleague from Bangladesh, we require a lab and better infrastructure to carry out IGRA, while SIILTIBCY can also be done in lower healthcare settings. The cost is lower for CYTB compared to IGRA, and we have a manufacturer who's a domestic manufacturer who has a high yield. So availability of this particular product is not an issue in our country. Now we are working towards expanding TPT to other high-risk groups. And since December, we've been working on it. We already have CYTB now available under the program, and we are using it for a specific population for doing a TB infection testing. And we are trying to parallelly scale up the shorter regimen of 3 HP and 1 HP for the people who 1 HP mainly for PLHIVs and 3 HP for close contacts and other high-risk groups. So we are trying to focus now towards improving the coverage in the household contacts, ensuring availability of X-rays so that we can rule out active TB in those who we are screening, and linking case finding along with TB prevention and ensuring that those who are tested positive are being put on TPT. We already have a Nixia module, a digital platform, where line listing of all those who are being tested for tuberculosis and are being put on treatment are all registered onto this digital platform. For TPT also, we have a special module where all the parameters related to TPT, be it testing, be it conducting their X-ray, be it treatment adherence, and be it a follow-up, everything is being recorded on this particular platform. And this is how we are following up each case, because line list of every case and every contact is available on this particular platform. When we talk about CYTB in our country, this is a new point of care test, and it is made in India. It was introduced in September 24 under the TB program. As we mentioned, it contains 2 proteins, and it is highly specific for specific tuberculin test. It was procured centrally at the national level, and it has been distributed across the country to various states. We have been procuring it, program has been procuring these vials from the manufacturers, and we normally do not store it in our central stores, and the manufacturer is supposed to deliver it at the state so that the cold chain is maintained properly, and further cold chain is being maintained at the states. At present, the test is being used for those above 18 years of age, but however, we have a recommendation to use it for those who are between 1 year to 18 years also. If we look at the key activities or the milestones that we followed for introducing CYTB, this was approved by the Indian regulator in May 22, and then we prepared technical specifications for procurement of this under the program. CYTB received ICMR approval first for up to 18 years, and now lately it received the approval or validation done by ICMR to be used for those above 1 year of age. We have completed domestic procurement, and we have ensured that since it requires a cold chain, VVM is being put on all our vials so that the cold chain and its validity and its viability is being monitored closely. We have supplied it to the states, and we are in the process of now using it for other high-risk groups also. So how did we prepare ourselves for rolling out CYTB? As I mentioned, that we prepared specific SOPs. We carried out trainings through videos, through preparing specific videos. But specifically is ensuring that quality of the way we give intradermal injection is well understood, and we give the injection and we do the test correctly. Our always approach is to use the systems, already available systems, whenever we introduce a particular commodity into the program. Similarly, for CYTB, what we did, we have an existing cold chain, and its capacities was expanded during the COVID vaccination. So those extra capacities that were available was used for CYTB for storage across the country. So there is no hindrance for any state, or there's no hesitation in any state that we do not have a cold chain capacity. So we earmark that a cold chain capacity is already available and you need to use the existing capacities. Similarly, in terms of syringes, we ensured that we were already doing adult BCG vaccination and those syringes were available. So those syringes were also being used. The manufacturers has been transporting the stocks in a cold chain and then they are being stored in the states in the available cold chain capacity. Sensitization, repeated sensitization and review is being carried out with the states to ensure better uptake and to ensure that we are carrying out the test properly. If we look at the performance, the test was introduced in September 2024 and till March 2024, around 1.13 million doses have been used. We had procured some 3.2 million doses for CYTB and till date 1.13 million doses have been used. And this is being used only for those above 18 years of age and mainly in household contacts of pulmonary TB patients. Other than that, we also have these other two tests that are available, though they are in the process of getting weaned out. So PPT, we have used PPT, especially in the tertiary settings in 51,000 people. And IGRA also has been used in around more than 2 lakh patients, 2 lakh people who are more than 5 years of age. So parallelly, we have all these three tests available, but slowly the country is moving towards CYTB and the other tests are slowly getting weaned out from the program. IGRA is something that was being procured by the state, supported by the center through the PIP process, but now the states have been advised to slowly move towards CYTB as it is a cheaper test and it can be used in closer to the community also. So what are the main learnings as was shared by my earlier two speakers? I think our experience has been quite similar to what people from Bangladesh and Uganda has already shared, that there is hesitancy among the program managers and the clinicians, as mentioned, that it is also affecting the coverage of TPT. So we need a multi-pronged advocacy strategy. Risk communication material have already been prepared at our level, and this is getting disseminated so that this could be used. And we are continuously share the available scientific evidence with the doctors, with the prescribing physicians, and we are trying to advocate ensuring infection testing and the close contacts of TB patients. Resources is not an issue. It is all being supported through domestic funds. Ensuring that ruling out active TB is something that is critical for us, and we are trying to build the capacities of having ample X-rays across the country so that we are able to rule out TB before we initiate them on TPT. We have a digital infrastructure monitoring system, and that continuously guides us, and not only for ensuring that the supplies are available, they are being used, but also to track the patients and look into the coverage and the outcomes and completion and adherence of TPT. However, the issue is real-time data entry that has to be done in the fields, and this is something that needs continuous training and retraining. That is something we are continuously working on. Concurrent operational research is necessary to understand the challenges and the way to strengthen the program. So when we talk about way forward, first, it is necessary that we do proper advocacy at the public and private health centers and also with the community. We need to ensure that CYTB is available till the last mile for storage. We need to build the capacity of the field staff for administration and interpretation. At present, we are using our midwives who are already carrying out vaccination and they are expert in giving BCG vaccination. So those people are being used. However, we need to build the capacities of other staff so that we will be able to cater to the needs of carrying out this particular test. Scaling it up in the household contacts is important, and we need to expand on the test and treat policy. strengthening of recording of use of CYTB and community engagement, and improve the health-seeking behavior in the community. So that is all from my side. I thank you for giving me this opportunity to share our experience. Thank you.
Thank you, Dr. Veena, for the presentation. So those were the three presentations in the Q&A box. It's quite active, and I see Sanjuti and Alex have already answered some of the questions, so thank you for that. We do have about 5 minutes left to discuss some of the questions. If you look in the Q&A box, you can see that some of them are answered. There have been quite a few questions about the use in pediatric populations, so those have been answered. One question I have, I guess, I found it very interesting from Alex's presentation. He made a comment about, well, there's data actually about a reduced hesitancy of contacts to start TPT and complete TPT when they have a positive infection results, right? We know in many countries there's hesitancy among contacts to start TPT when they feel healthy and there's no test result at all. So I'm curious, in India, Dr. Veena, do you have any data that has shown that there's a reduced hesitancy to start TPT when the patient has a positive test result?
At present, I don't think we are in a position to answer this question, because as I mentioned, that real-time data entry into the system is yet getting strengthened. So I hope as we move ahead, we would be able to evaluate that and we would be able to share that with you. But yes, we do agree that when we have a positive test, it is a push for a particular beneficiary to initiate a treatment, and the hesitancy, and it is better, we can do a better advocacy if somebody has a positive test. So this is an observation, but we do not have at present data to prove our observation.
Thanks. Beatrice, did you want to ask a question?
Thank you. I note from Alex's presentation about the use of the TST to guide people with people who had access to TPT or who got access to TPT. And I'm wondering for Sanjuti or for Dr. Veena, within your projects, have you been able to evaluate the costs avoided by using TST to support or to guide TPT prescription? Or looking at the cost effectiveness of using TST or SIILTIBCY?
At present, we have not done that evaluation, and I think that is a food for thought, and we would surely want to do it. But it is important that we scale up the initiative first, because it's only 6 months into the program, and India is a huge country. I think it is too early to answer that question, but I think that's a nice question. We have noted it down, and this is something we could be working on.
Over to you, Wayne.
Yeah, I thought Sanjuti might want to answer.
So same with Veena. From this study, maybe we are not in that position to, calculate the cost effectiveness study, but it would be very important to, calculate the cost effectiveness of this reagent. Thank you.
Okay, thank you,
Cost
Sanjuti.
effectiveness of Thank you.
Right. Okay. There's a couple questions about cold chain and how that can be assured. I'm curious if you have SOPs about that. What do you do if there's suspicion that the product was not kept between 2 and 8 Celsius?
As I mentioned, we already have a VVM on our vials. So in case there is a breach in the cold chain, it is reflected on the VVM, and those vials are then not used and they are to be discarded as per the SOPs that have been issued from the center.
Okay, thanks, Beatrice.
Thank you. Maybe the last question I will ask is from Edine. Have you seen any difference in terms of the induration sizes, or is it easier when you compare on how to palpate the induration for SIILTB when you compare to the Mantoux test? Senjuti or Alex?
So thank you. Thanks again, Via. So no, as TST is widely used in our country, so our staff are very much familiar for measuring the TST. So as it was as same as CYTB measurement was as same as TST, so we didn't find any difficulty for measuring the CYTB test. Thank you.
Thanks, Senjuti.
I think she has responded, but I don't know if it is. I had responded to the issue of measuring the induration. I think this has been the key one. Initially, if the indurations are small, they are likely to be missed. So what we found very important was if you mark the point at which the test is administered with a pen, then when you return to read, you palpate. If you feel an induration, the best is to use the ballpoint technique. So you mark like 2 centimeters away from the reaction, and then you move your pen towards the center of the induration. Where you feel resistance, that marks the beginning of the induration, and you do that on the opposite side. Mark that and measure the largest diameter. And we found this technique easier to use alone instead of, relying on mere palpation to get the margins. The other thing is that the indurations are actually not small, much as the manufacturer puts a threshold of 5 millimeters. The indurations in our study were big, and I've provided information on the diameter. About whether we need we can remotely measure the indurations. I think my lab had an app or something they were working on to see if one could take the images, the pictures, and then read remotely the indurations. We did take the before and after photos of these indurations, and would be really happy to contribute if you would like to come up with a model that could be used to read these indurations remotely. Over.
So as mentioned by Alex, in India also there's some work going on using an AI tool to read it remotely, because the issue that we face is when the patients need to be called back or we need to reach out to the patient for reading. So this is something India we are working on, and I hope we will be having some good result out of it. That will help us to scale up it even better.
Okay, thanks everyone. So we are now 5 minutes past the hour. There've been, I see in the Q&A box, 15 of the questions have been answered. There's still 20 of them open. We don't have time now to go over all of them. What we're going to do is Beatrice and I will work with each of the presenters to answer all of the questions in a written form, and we'll be following up after the presentation and sharing that. We'll also work with the Serum Institute of India and their collaborative partner manufacturer, MyLab, to answer some of these questions as well. And as Dr. Veena said, there's the work they've been doing on having an AI mobile phone reader that can be used. So we'll share that information as well. So I think we do need to close. So On behalf of Stop TB, we'd like to thank everyone for joining. And we'd like to thank in particular Dr. Sanjuti from ICDDRB, Dr. Alex from Wallamoo, and Dr. Veena from the India National TB Elimination Program. And as I said, we'll be following up. We're going to be also sharing people's presentations, and we'll share that with everyone who has registered. Please reach out to us at Stop TB if you have any questions about the tests and if there's any way we can be of assistance. So again, thank you everyone, and goodbye.